Rainer, thanks a lot for this great invitation, and I really enjoyed the previous talks. My talk is focusing on the long-term consequences of traumatization, and I will largely focus on clinical consequences, not so far on neurobiological findings, but more or less at the public health perspective. And I'm currently living in Germany at the Baltic seaside coast in the small town of Greifswald. I have a professorship for psychiatry. This is the old university building. Down below, it's my clinical team. And in the bottom left, you can see some parts of the new hospital building of our university. Yeah, we are running the study of Pomerania, and this study has been launched in 1997, a long time ago, and this was one of the main reasons why I took the long way from Bonn, where I met Rainer, to Greifswald in the Wild East that time, right after the reunification. That it was really a very challenging task to work in the field of epidemiology in a very, very new area of Germany, let's say new in parentheses, where a lot of new infrastructure had to be rebuilt, and a lot of scientists were really needed to put all their knowledge into the upcoming projects. And yes, we didn't really know if the old story would end up in something like a success story, but finally, after 25 years, I have to say that we were pretty successful. We conducted the ship baseline study. We continued with the ship 1, ship 2, ship 3, and currently also ship 4. And in between a psychiatric assessment study called Legend. We have launched a second cohort called Ship Trent with a first follow-up, and we have now a third cohort that is not indicated in the slide. It's called Ship Next. So the whole field of epidemiology is really moving forward, and I enjoy it very, very much. And the data that I'm presenting from our side are coming from this study, but I will also refer to a couple of other studies because yes, it's important to broaden the scope a little bit. You can see some parts of the chalk cliffs at the seaside of the island of Rügen. This is our MRI scanner for the ship study, and this is just a plot of a genetic association summary diagram. So we are running a lot of different scientific projects, and but today I will not focus on genetics. Largely, our approach is a multi-systems approach, where we are really trying to integrate life events, biological levels of information, MRI, scans, and also functional MRIs. And we want to know how all these factors interact at different life stages to produce something like mental disorders, or to set the risk tone for the emergence of mental disorders. Yeah, a couple of years ago, a study was published in Lancet, which was quite famous, the burden consequences of childhood maltreatment in high-income countries. So yes, I think the broad scientific community and also the clinical community was pointed to the fact that childhood maltreatment is really a pervasive problem also in high-income countries, although psychiatrists were aware of these factors all the time. Back that days in 2009, they summarized the existing evidence for the prevalence rates, like 4 to 16% of the children were physically abused, and 1 in 10 is neglected or psychologically abused, and 5 to 10% of the girls and up to 5% of the boys were exposed to penetrative sexual abuse. which are pretty high figures. And if you calculate this at the level of a population, you end up in millions being abused, for instance, in Germany. So this is really a tough thing to understand and a tough thing to acknowledge in the health system. But I want to move forward to new data, to other data, and like I mentioned before, in the clinical perspective, it's pretty clear that a lot of patients that show up in our outpatients department or in the inpatient units have a history of broken home, a history of childhood maltreatment, of neglect, and also of abuse. And you can see it when you talk to the patients, when you take the medical history. You can see it in a broad range of disorders, especially in depressive disorders, of course, in borderline personality disorders, also in anxiety disorders, schizophrenia, in drug and alcohol abuse, and so on. It's really all over the place if you ask the right questions. So it seems to be very prevalent in psychiatry. And what I'm going to try now is to go into the general population, to the field of epidemiology, and to add some scientific hardcore data to the story. Maybe some of you are aware of the German National Cohort Study. It's a nationwide study with a lot of study centers throughout Germany. In this analysis, we have entered almost 76,000 or 77,000 German individuals. This is not the whole cohort. Meanwhile, the national cohort has completed the baseline assessment with 205,000 German inhabitants. And currently, after baseline, they are working on the first follow-up study, which is pretty nice because it's a huge study with, like I said, 200,000 people, partly with MRIs, with genetics, and with deep neuropsychological assessments. What were we investigating? We were investigating the CTS. It's the Childhood Trauma Questionnaire, or the screener. Maybe some of you are aware of the questionnaire. It's a 28 item questionnaire. We reduced this questionnaire to 5 core questions, reflecting the 5 different dimensions of childhood maltreatment. So it's broken down to physical neglect, to emotional neglect, to physical abuse, to emotional abuse, and to sexual abuse. With this childhood trauma screener, we performed a couple of validation studies about 10 years ago. And when we are using the cutoffs that we have established back at that time, you can see at the very right column that physical neglect was present in about 11% of the participants, emotional neglect in 8%, physical abuse in 8.6%, emotional abuse in 8%, and sexual abuse in about 6%. So, of course, sometimes a participant has a couple different maltreatment forms. So these are just figures for the individual thing. And in the end, it adds up to a prevalence rate of more than 10% in the German general population. And I have to say that this survey is pretty representative. Of course, one has to acknowledge that really underprivileged areas of cities and participants or inhabitants are usually not so prone to participate in these studies because you have to be aware that you have to answer a lot of different questions, that you have to fill in a lot of questionnaires, and you have to be pretty smart to be able to participate successfully in such a large cohort study. So I would really assume that socially disadvantaged people have a lower participant rate in such kind of studies. And so these are the prevalence rates when we're talking about the people who are willing to contribute to such a study, which really takes hours, almost a total day. So, and referring to the same data set, we were associating these childhood trauma scores to depression. You can see here the PHQ-9. This is a depression score. The GAD, this is general anxiety, and PHQ stress is a stress score. And you can see in the dark bars here, this is maltreatment yes condition, and in every instance you can see that abuse and neglect, of course, is associated with higher scores in depression, high scores in general anxiety, and high scores in stress. And one is probably inclined to say, oh, yes, we expected this. Yes, of course, we did expect this. But, you know, if you really go into the broad general population and you are referring to 5 questionnaires that are addressing some issues of your childhood that have been, I don't know, 30, 40, 50 years ago, that happened 50 years ago, you know, the connection between all these childhood environmental things and the present is really very distinct. And not everyone is really suffering from a severe degree of mental disorder, but you can see in the mean scores are really highly significant. And this is somehow remarkable in this perspective. So the bottom line story is, yes, even if you go just with 5 questions into the field, if you just ask these simple 5 questions, I just go back, you can see the wording, you know, the wording is pretty simple, it's easy, it's not difficult to answer, that these items are really indicative for excessively higher scores of depression, anxiety, and stress in the general population. Okay, this is something from our Greifswald-based study, from the SHIP study. I presented this slide last year already, but I still think it's very interesting because here we associated the 5 different dimensions with an interview-generated lifetime diagnosis of MDD, of major depressive disorder. And we were really dealing with the differential forms of childhood maltreatment. And you can see that emotional abuse was really the highest risk factor for lifetime MDD, with the odds ratio, with an odds ratio of almost 4, a 4-fold increase in the risk of lifetime MDD in the general population when somebody is indicating that emotional abuse in a moderate to severe form happened in his or her childhood. And if we summarize these scores at an individual level, we see overall abuse dimensions were met in 9% of the participants and overall neglect in 22%. So these figures are pretty comparable to the overall German assessments in the NARCO study. Which really show that these are base rates in the population. So our population in Greifswald and in the area, it's, you know, it's very, very rural area. It's you know, socially, it's everything is okay. No bad things are truly happen, and no real tough criminal areas or something like this. But this is the base rate. I don't think that you can get lower figures in Germany. Yeah, and I would like to jump to the topic of psychosis, which is a little bit hard to investigate at an epidemiological level, because psychosis, or at least schizophrenia, is not that frequent. And you can imagine that a lot of people suffering from schizophrenia are reluctant to join such complex epidemiological studies. And yeah, it's a model. It's a model that summarizes a lot of scientific evidence concerning the emergence, concerning the mechanisms that are underlying psychosis. And the current concept goes like this: you have first wave hits, you have second wave hits, and something might happen later on when you already have developed the psychosis after the first episode, that you have still some psychosocial hits that are triggering relapses. The first wave hits are, of course, hits that are occurring before birth or around birth. It's obstetric complications, for example, traumatic brain injuries, and so on. But also the topic of childhood trauma, emotional abuse, physical neglect, and so on, because these types of maltreatment are also connected to a whole set of psychosocial stressors in the families and in the living environment. And also here, childhood or adolescence low function and so on, and drug and tobacco use. You know, it's all interconnected, and childhood abuse and childhood trauma are some kind of hallmarks of pathological child development. Yeah, and now I would like to come to some of the physical consequences of childhood trauma, at least at an associative level. Concerning the model, it's like childhood trauma occurs, and childhood trauma is somehow connected to mental problems, also during childhood and adolescence, and of course during the adulthood. You have an increased rate of depression, like we've seen, of PTSD, for instance, anxiety, and so on. This is pretty clear from the perspective of psychiatry. And then you have the physiological levels, that you have an activation of the HPA axis. This is quite interesting, because during the active trauma phase, you probably do have the activation of the HPA axis. You do have elevated cortisol levels. But later on in adulthood, you have lower cortisol levels, showing something like desensitization of the HPA axis. So the stress response system is adapting to the childhood trauma stress, and later on, it's more or less not that responsive anymore, which might be protective to upcoming new stresses, but which also might have some downsides, because all the regulation of the immune system that also relies, at least in part, to the production of cortisol doesn't work that well anymore. You can have something like chronic inflammatory markers, chronic inflammation, and you can end up having other metabolic problems. And in the end, it's pretty clear that the whole complex will end up in altering your behavior. Your behavior is altered, like you try to relieve yourself, you're trying to maybe to self-medicate yourself concerning intrusions and really adversive other experiences. And you know, when you end up drinking too much alcohol and smoking, and when you end up taking drugs, it's definitely bad for your social adaptation. And usually your physical activity goes down, and your nutrition doesn't work that well anymore. In the end, we have pretty good evidence that cardiovascular disease are increased in long-term follow-up of childhood trauma, and I can show you some data later on. Yeah. So nice arrows. Let me come to some autoimmunological disorders like rheumatoid arthritis and multiple sclerosis. First of all, this is a study that we conducted a couple of years ago, where we're just comparing people with rheumatoid arthritis, more than 300, with the control group, and the healthy control group, and we're simply comparing the rate of the abuse and neglect dimensions. And you can see that in the group of rheumatoid arthritis patients, we had with odds ratio of 0.6, 0.5, 2.1, we had large increase, double rate at least, in the history of such kind of abuse and neglect phenomena, which is kind of indicative for a burden of these maltreatment events in the group of patients that developed rheumatoid arthritis later on in life, which is usually taking place in the 30s, 40s, or 50s of age. So it's a long time consequence of probably immunological dysfunction in people that were suffering from early trauma. And the other study, which we conducted in multiple sclerosis, yielded quite similar results. We had, again, a group of patients with multiple sclerosis, control group, and we were just comparing the scores in this respect, the dimensional scores of the childhood trauma questionnaire. And you can see, for instance, emotional abuse, mean scores were 9.2 in the patients with multiple sclerosis, 6.7 the control group, highly significant, or maybe here sexual abuse, 6.0, 5.3, emotional neglect, 11 versus 9. So there was some kind of increased score, and yeah, it was clear also the total score about 40 to 33, also highly significant. So this is another piece of evidence that something's probably going wrong with the immune system, trying to delineate self from other immunogenic targets. So the distinction between the self from the body and the other pathogens that needs to be attacked doesn't work that proper in patients with childhood trauma. Yeah, and now I want to cite the ACE study. It's a pretty famous study conducted almost 20 years ago from health insurance databases, and yeah, they found evidence for childhood experience being connected to chronic obstructive pulmonary disease, to ischemic heart disease. I will go into details further in a couple of minutes, and also to the autoimmune disease that I've just indicated with the two studies of ourselves, and yeah, liver disease, self-reported liver disease. We've recently performed a study last year where we were investigating the association between childhood maltreatment and lung function in our general population study. And the point was that we tried to compare the occurrence of clinician diagnosis versus objective lung function measurements. And you can see here CM plus is childhood abuse positive, and this is childhood childhood abuse or childhood maltreatment negative. And you can see that, the people with childhood abuse, they reported a higher incidence rate of asthma, 7.7 against 4.6. Also, the medication against asthma was taken more frequently. Then they had problems wheezing without having a cold, woken with chest tightness, woken with shortness of breath, woken by an attack of coughing, and asthma attacks. So these were all with positive odds ratios, with adjusted positive ratios, and some of them of these associations were significant. And so at first sight, this seems to support the previous literature, and I think this is, of course, true that the subjective complaints are higher and that they do have more problems with lung function, but probably they are being treated in a very appropriate way, at least in Germany, because when we go to the objective measures of lung function, like here, you can see all the abbreviations like the force, vital capacity, peak, expiratory flow, airflow limitation, and so on. All the objective measures that come out from such a lung function testing, pulmonary testing. You can see that overall there's no significant findings between the groups with childhood maltreatment positive, childhood maltreatment negative. So this does not mean that they have no problems, but probably they've been treated well, at least in Greifswald and area. But it seems to be at the clinical level, it seems to be a problem, and it doesn't contradict really the previous studies. So, and now I want to go into some details of the ACE study and concerning IHD, it's ischemic heart attack. It's a very prevalent condition. It's a very devastating condition leading to disability and to heart attacks and sometimes to heart failure. So, and the ACE score, this is the Adverse Childhood Experience score. And you can see here on the left side, 0 is pretty, everything's okay, pretty absence of any kind of abuse. And this score can increase up to 7 to 8. This is the maximum score that you can achieve when you have experienced a lot of childhood traumatic events. And for all these different groups, they conducted statistical analyses calculating the risk that was associated between these levels of childhood adversity experiences and the rate of ischemic heart disease. And you have different models. Model 1 is almost not adjusted. It's just adjusted for age, sex, race, and education. And you can see here the null, the absence abuse group is the reference group, of course. You can see here an increasing odds ratio up to 2 and also 3.6 increase in risk in the group of subjects who were exposed to severe forms of childhood trauma. And when you then go through all the different levels of adjustment, for example, model 2, adjusting additionally for traditional risk factors like smoking, physical activity, body mass index, diabetes, hypertension, you can see that the odds ratio are, of course, going down a little bit, but not so much. When you then go on and you adjust for psychological risk factors like anger and depressed affect, and this model 3, you see again a few decreases in the effect size, which is fair because childhood abuse is associated with a lot of psychological phenomena. And when you then adjust for everything, if you really take all the confounders together, you end up with a 1.5 or 2.3 increase concerning ischemic heart disease. So this is very, very conservative because I think a lot of these factors are also mediators between childhood abuse and ischemic heart disease. You can't say that they are really totally independent. For example, if you start smoking because you have to regulate yourself, your emotional tension, for example, or you're physically inactive because of the childhood abuse that turned you into a depressed mood. These are mediators, and so this is, from a statistical point of view, this is a really, really hard adjustment, and you can say at least double in the effect size and the rate of ischemic heart disease, and maybe between 3 and 2. And I think it's a great study, and it's very important contribution. So, and I would like to continue with some of the newer data sets. It's a study from the Czech Republic, a very nice study performed in 2 samples. One sample with 1,800 participants, the other about 1,000. And they also used the childhood trauma questionnaire, and they were investigating a lot of different physical conditions. I hope you can see it. So the numbers are odds ratios, and the bars are the confidence intervals. And the 2 different colors are blue, the Czech respondents, and the green bars are the Slovak respondents, the 2 different study types. And I just want to draw your attention to a couple of associations. For example, arthritis. Arthritis, again, is something where we see high odds ratio, at least in one of the samples. When we go to asthma, again, asthma is a condition that we've heard about before. Lung dysfunction, again, very high odds ratios in one of the studies. Also in the other, a 2.4 increase in lifetime rate. If we go to allergies, and especially when we go to the mental disorders, depression and anxiety, we have a huge increase, but this is pretty clear from a psychiatrist perspective. And I want to make the point that especially pain disorders, back pain and pelvic pain and other pain types are also very, very highly related to childhood trauma. It's a recent study, and I think it's important to acknowledge that all these conditions are really increased in subjects after childhood trauma. There might be some questions concerning the eczema. I'm not quite sure how robust this is, but in the end, you see the figures by yourself. So it's a true, strong health problem. Just a few data from the MRI, and you can see here, like I mentioned before, that that everybody goes through different phases of brain development and personal development and skill development, and that, of course, different types of stressors can affect the brain development in different ways. It's something different if you have prenatal stress or whether you have postnatal stress or stress in adolescence and so on. So this is a nice study from Sonia Lupin that was trying to investigate partly also based on animal experience to figure out which brain areas do suffer from stressors in different phases of development. And yeah, I think when we transduce this to the human setting, it would be very important for brain research to really pin down in which phases, also in childhood versus adolescence, in which years of development the stresses really took place. Sometimes it's something like between the year of 2 and 10, it's a long-term stressor, but sometimes you can probably be more precise with the periods of stress exposure. Yeah, and this is a finding that has been replicated many times, that childhood maltreatment has an association with reduced hippocampal volumes. Yeah, but then it's quite the question: which other brain areas are involved in the long-term reaction to childhood trauma? A couple of studies have been published, but the results are not that consistent. Most studies do find something, but sometimes in various brain areas. And our feeling is that it really also depends on the adaptation to childhood trauma. When you go to the clinical department, you usually see patients that do suffer from long-term consequences of childhood trauma because they are still sick, they are still in the need of treatment, and they come to the outpatient unit. But if you go into the general population, you really do meet a lot of patients or subjects who performed quite well, irrespective of their childhood trauma, and you have to take this into account. So we were conducting a study from our general population where we were really looking at the interface, the interaction between childhood trauma and depressive disorders. Because when somebody who has experienced childhood trauma do suffer from recent depressive episodes, one could assume that this is somebody who has not been able to cope that well with all the stresses of childhood, and that this could be something like a long-term consequence of childhood abuse. And you can see here in this plot that this is whole brain volume, cortical whole brain volume. And you can see at the bottom, no abuse, mild abuse, and moderate, excuse me, this is severity of depression. No depression, mild depression, moderate to severe depression. And here in the different colors of the figure, light, no abuse, dark, abuse. So this is the abuse group. And you can see that the abuse group without any signs of depression has pretty good brain volume, pretty high brain volume, gray matter volume. But when it comes to mild depression or to moderate or severe depression, this group that has experienced childhood abuse has a significantly lower brain volume than the no abuse group. Because the no abuse group, here the brain volume largely remains the same, irrespective of the status of depression, whether or not depression is present here or not. So in the interaction between childhood maltreatment and depressive symptoms, you can see that there is a strong drop in gray matter, cortical volume, like one would expect from previous study that already have suggested such an association. You can see here in red the areas where this volume reduction takes place. So it's not all over the brain, but there are some distinct areas that have high indication of loss of volume in the interaction between childhood maltreatment and depressive disorder. So I'm almost coming to an end, and I would like to mention that childhood maltreatment and depression are, of course, linked to economic burdens. It's a very nice paper published this year from the author list. You can see it. And they have huge tables. I was not able to show these tables here, but the storyline is really that childhood maltreatment is associated consistently with lower education, with lower income, with higher rates of unemployment and part-time rates. And if you add depression to these models, depression acts as a strong interaction factor, as a strong moderator, and everything becomes even worse. You know, if you are suffering from childhood trauma and from depression, all these figures become more severe. And this is a pretty good, well-situated German area where this investigation took place. And you can really see that besides all the mental health and the physical health issues, the childhood maltreatment is really associated with a bad, worse socioeconomic outcome. So you don't have the opportunities that other people in Germany do have concerning their professional development and their economic growth. And this is almost my final slide. Like I mentioned before, when we go into the general population, you can see that people here with childhood trauma, yeah, sometimes they do have something that we call low resilience, that they have low self-confidence, that they have a lot of problems, a lot of worries, that they don't expect that they can really achieve something. But, you know, this doesn't happen all the time. If you go into the other group here, this is a group that has also experienced moderate to severe childhood abuse, but at a somewhat lower rate. You see that this group, yeah, there are also a lot of participants that say, yes, I have experienced childhood abuse, but I'm still here in the middle of my life and I have a high score of resilience. And I'm self-confident and I have somehow overcome this burden of childhood trauma. On the other hand, you have people in the general population without childhood trauma, of course. And yeah, interestingly enough, you have both groups in this group as well. You have a high proportion of people with low resiliency. They have no childhood trauma, but they have no huge degree of self-confidence. And the other way, here you can see, yeah, pretty high rates. And I just want to show you in these four groups, the rates of lifetime major depressive disorder. This is the group with no childhood trauma and with high resilience. You have a base rate, it's the lowest rate, of course, of 11%. If we take the most severe group, the childhood trauma positive and low resiliency, you have almost 30% of lifetime MDD, and the other two groups are in between 14 and 18. So it's important to acknowledge, at least in the general population, to acknowledge somebody who has experienced childhood trauma, of course, but then you have to ask further questions. How well could you cope with that? Have you been experienced depressed mood? Are you still depressed? What about maybe your personal score of resiliency, and so on? So the outcomes are diverse, and not everything is really bad, even if you have experienced a worrisome childhood. Yeah, this is my summary, my discussion. Childhood abuse is a very prevalent condition, childhood neglect even much more. You have a high association with different mental disorders and also with physical disorders. And you have a strong alteration of psychosocial development and psychobiological factors. And there's a huge type of research that is also focusing on very interesting new components like microRNAs that are probably connecting traumata to transgenital effects and transmissions. But this is something that needs to be explored more further. So thanks a lot for your attention. Yeah, and I'm happy to take questions.
Okay, yeah, thanks so much. I just try to get my face on here and get other people's faces on. Yeah, so thanks a lot for this very exciting talk and very careful talk. The question is, one of the things I was wondering, you haven't talked about gender differences. So that's something, is it just for the females or for the males, where is it? So, and where comes the resilience from? So where is resilience, where is it, where can you find it? And the third thing was, how comes that, the Slovak response so much different from the Czech, and I can't know what in this study, but that looks weird, so is it a selection effect or is it a poverty effect, or how can you explain that? I'm not sure which study it was, but, so
Yes.
gender resilience and whatever, south, east and west of the country.
Yes, so wonderful questions. Let me start with the last one. I have no true explanation for these differences. These are weird. There might be difference in the study setting. However, the questionnaires were the same. I do not really expect that these are true differences. Maybe it's something like an factor of the healthcare system, because they were assessing the given diagnosis. They were not making their diagnosis in the study, but they were asking the participants, have you been experienced, I don't know, diabetes, or have you experienced arthritis, and so on. And if they say no, because no physician had ever made these diagnoses, then it's no, So maybe these are also structural differences, but it's kind of weird. But it indicates the range, the possible range, if you go into the general population and in different settings, different countries, there might be a range where the methodological differences really produce different figures, but still consistently it's an increase concerning the most diagnoses that were investigated. The point with the gender differences, it's very interesting, but there is no such huge gender difference. There's some kind of gender difference in sexual abuse. You have slightly more females that are indicating sexual abuse, but the other rates are pretty similar between both genders. There's no big difference. Yeah, this is cool. And third question. Resilience. Yeah, we had a questionnaire. We had a questionnaire. It's called the RS25. And you have a couple of questions, 25 questions, where you're being asked about all the capacity of positive thinking, of self-confidence, of doubt concerning your own personal achievements, and so on. And in this study, we dichotomized this RS25 score separately for both genders, because there's a gender difference between males and females, but it was dichotomized individually. Yeah.
Right, I think Daria has a question, I think from very specific population. Do you want to go yourself, Daria? Daria from Daria Ahmad, do you want to go?
Yeah, thank you very much. So actually, I have two questions. One is, if you have data, Professor, is there any differences between the trauma of children who are associated with the criminal and terrorist groups with the normal children? Right now we have a lot of cases from Yemen, from Syria, from Nigeria and Iraq. The children who are affiliated with the criminal and terrorist groups, now they are receiving the psychological treatment, but they have a lot of psychiatric problems like PTSD, depression, and anxiety. So do you think your data is talking about the same thing? Do you think these are two groups, the normal children and the children who are associated with the criminal groups, have the same issue, the same problems that you are presented in your presentation? This is the first question. And the second, what's the best psychological intervention and rehabilitation for these groups? the children, the traumatized children who are associated with the criminal groups?
Yes, I think our data come from the average general population, and it's not a population that has been traumatized in a very severe degree in the last decades. When we take a look at our oldest participants who were born in the Second World War and who have experienced the time after the Second World War, you can see that they are indicating a high degree of physical neglect, which is quite reasonable because these questions are us asking about food, about clothing, and so on. And this was really a devastating fact back in these years, and they really had highest scores in physical neglect, but the other scores were pretty normal. So we can see in our data, we can see effects of some different decades throughout the German history that are associated with large societal developments. And if you go into areas with a high criminal load, or if you even go, like you mentioned, in areas with warfares and high degree of criminality, yeah, it's becoming more worse, and it's devastating because these are traumatizations in the most severe forms, and sometimes the kids are being victimized, and sometimes they are being forced to be the traitor. It's a mess, and it's really, from a psychological perspective, it's devastating. And yeah, there are a couple of trauma therapies. I think a colleague of ours in Germany, in Constance, he has developed the narrative exposure therapy, which is quite appropriate for people who have been traumatized during warfares. Personally, I like EMDR very much because it's very effective, it's very it's time efficient, and you can really reduce intrusions and flashbacks to a very a relevant degree. It's really very effective. In our clinical settings, we are now using the IRRT. It's the imaginary reprocessing and rescripting therapy. You have to be educated in this therapy, but it's really brilliant to make partly something like an exposure part of the therapy, that you expose yourself to the traumatic events, and that you then are re-entering the traumatized scene back then in your childhood or adolescence, and that you are entering the scene with your present adult personality. So you are entering the scene as adult, and you see yourself as child being abused by somebody, and then you can intervene into the scene. You can do something with a traitor. You can do something afterwards with the child, with the own child. You can consolidate the child. You can talk to him or to her. It's really a brilliant type of therapy, very effective. But when we are coming to something like countries in chronic civil war and devastating economic situations, I would probably prefer something like EMDR because it's more time efficient, and yeah, probably the narrative exposure therapy. Yeah.